Thank you. Now moving on to the next topic of bicuspid aortic valves. As we see more and more intermediate and lower risk patients getting TAVR, we're seeing a considerable number of those with bicuspid aortic valves. There is data from the TVT registry suggesting that TAVR in bicuspid aortic valve was comparable to that in the tricuspid aortic valve population. But having said that, there's considerable variation in the anatomy of bicuspid aortic valves. It would be great if you could sort of share your approach to patients with bicuspid aortic valve needing AVR.
Question. So thanks for asking about bicuspid valve, because I think it is a cohort of patients that we really have some questions about, primarily because they were left out of all the original clinical trials. When we looked at the TVT registry, you talked about one of the papers that was written. In that registry paper, only 3.4% of those patients who had TAVR were bicuspid. But now that we're doing low risk patients, 50% will be bicuspid because of their age. And the question is what to do with these patients. The surgeons, of course, think that we should not be doing TAVR in anybody under the age of 65. And I think that it's a little reductionary to say that, because there are some patients, of course, that are less than 65 years old, which are at a higher risk. And so age alone does not stratify them. In the TVT registry, of course, all-cause mortality, stroke, and valve hemodynamics were not different at 30 days or 1 year when we compared bicuspid and tricuspid valves. This most recent study that was done in the self-expanding valves. And so there was earlier data, of course, in the SAPIEN valve, but the most recent data that's out is in self-expanding. And in that group, a small number of these patients needed reintervention at 30 days and at 1 year. And so at 30 days, the people who needed reintervention, it was 0.8% versus 0.7%, and the p-value was 0.03. And at 1 year, it was a little wider. TAVRs needed more reintervention at 1.7% versus 0.3% in the surgical group. And the p-value was significant again at 0.01. What's interesting to think about is that bicuspid valves is not just a valvular problem. It really is an entire chest problem. There is certainly aortopathy. There's dilation both of the aortic root and of the ascending aorta really frequently. Sometimes you have atypical location of the coronary ostium, and so that makes it more challenging to treat or place a valve. There's asymmetric leaflet calcification, which can make it a higher risk to do a TAVR. The annulus is often larger and makes it a little more challenging to treat as well. High calcium scores make it a little bit higher risk. And in the SAPIEN trial that was shown earlier, there was a little bit concern about a little bit higher risk of stroke, but that really didn't bear out at 1 year. But bulky leaflet calcification, fused raphe, all those things are really concerning. And in the trials, early on, we were using the first generation devices, and these first generation devices left more paravalvular leak. They had more device malpositioning, and aortic injury was more frequent. And so we have really seen with the research and development done by all the companies involved in the technology that it certainly has paid off, because the risk of these complications has gone down substantially. I think that what we are going to end up needing to do until there are randomized clinical trials specifically in the bicuspid population is look at subgroups. And there is a great paper that looked at bicuspid valves that were done. It was predominantly SAPIEN valves, 740 patients with SAPIEN. There was only about 188 that had the Evolut or Evolut Pro device used. And what they did is they really specifically looked at the valves and determined the calcification, whether the raphe were calcified, whether there was a lot of leaflet calcification. And those patients that had those two entities really had an increased risk of procedural complications and two-year mortality. They also had higher risk of aortic root injury. They had a higher risk of paravalvular leak and a higher 30-day mortality. So I think that not all bicuspid valves are the same. We can't really just look at them as a group. And I think we need to subset them, particularly before we have large clinical trials which show us definitively how to treat. And possibly we should, once we look at the valve, say, okay, this person has a porcelain aorta, they're a higher surgical risk, even though maybe their STS is low, and they should not have surgery. But when people have really calcified leaflets, really calcified raphe, they don't do well with TAVR. They have, again, they have more aortic annular ruptures, more paravalvular leak. And so those folks should not have TAVR. And so I think that that is a great way to stratify until we have all of the data. Certainly, if we don't have femoral access and we're going to use something alternative, that increases the risk. So maybe consider surgery in that group. If we have a lot of left ventricular outflow tract calcification or a low takeoff of the coronary arteries, again, TAVR is not preferred. But I think all in all, we have to remember the premise for all the clinical trials, which was that in order for TAVR to be approved and accepted, it had to meet or exceed the surgical outcomes. And so in a low-risk, straightforward bicuspid patient who has a beautiful aorta, they should have surgery. Now, the patients aren't going to like that, but really, we don't have enough data in TAVR to know that they should just go straight forward for TAVR. And again, and then the patients that have really high risk findings on a CT evaluation of their valve, calcified raphe, really severely calcified leaflets, they have a much higher adverse event after TAVR. So again, should be a surgical candidate unless there's some reason not to do surgery. So sort of just trying to wrap this all up, it doesn't seem like as a group they do worse whether we do surgery or TAVR. But when we start to break it down and look at them, there are certainly some groups who do better with surgery or do better with TAVR. And I think until we have definitively information that tells us one way or the other, we have to look at the anatomy and really do what's best for each individual patient.
Great. Thank you so much, Dr. Skelding, for joining
You're very
us
welcome.
and sharing your insights. Thank you, everybody, for watching.
All right.